Hi viewers, welcome to Decoding CTO Case 36. I'm Dr. A. Sharath Reddy, Interventional Cardiologist, Medicare Hospitals, Hyderabad. In this, I'm bringing a case of Retrograde RCA CTO PCI through LAD CTO and success after a failure. This patient is a 66-year-old male, came with an acute coronary syndrome with non-ST elevation, non-QMI, and he underwent CABG in 2005 with the grafts to D1 and RCA and Lima to LAD. And this patient had, during this non-QMI, there is a significant lesion in graft to diagonal, which I would show, and SVG to RCA was occluded long back. So these are the comorbids he had, and what is more important in his history is he had recurrent heart failure admissions before in 2015, 18 and 21, so which actually marks the importance of complete revascularization. This was the angiogram when he got admitted with non-QMI. You can see LAD CTO, native LAD CTO, and there was a lesion in LCX, but it's pretty okay. And this was his native right coronary artery. You can see it's a total occlusion, and we can see right coronary artery is filling from left system predominantly, and also from LAD, which was filling from SVG and Lima. This was his Lima, showing good flow to this LAD, but it looks LAD is kind of type 1 LAD. It's stopping short of apex. And this was the graft to diagonal, which showed a significant lesion, so almost like 99% lesion at distal as well as ostium. And he had severe LV dysfunction that time and was in decompensated heart failure. So we immediately fixed this SVG2 LAD lesion with 2 stents without even filter, with IVAS guidance, and post that his LV function improved and EF became 40-45% in next 6 weeks to 3 months. This was his anatomicogram. Since he had a significant myocardium at risk of ischemia, like more than 10%, and also viable myocardium in RCA territory, we advised PCI to RCA CTO. The points here is it's a long CTO, and there was an ambiguous proximal cap, and there was an SVG on distal RCA, which is close to crux, and CTO is almost extending up to crux. It's a kind of even ambiguous distal cap as well. So that overall is CTO is very high. And if you look at his retrograde options, so he had nice septal collaterals, but the problem was the LAD, there was a CTO, and yes, there was patent diagonal and patent Lima to LAD, but of course we can't use this diagonal SVG or Lima for a retrograde intervention. So as the angulation is too complex and chances of complications are quite high. So what we can use is go through this LAD CTO for retrograde to RCA CTO. So yes, I mean, these were the challenges. Ambiguous cap, so we can go retrograde fast and then we can start antegrade wiring, and there were interventional collaterals, but they were beyond LAD CTO. So that makes us mandatory to open LAD CTO before going retrograde, and also need of triple injection to visualize your retrograde vessel, which can be managed by stepwise dual injection to open LAD CTO first and then take same guide in diagonal into. Yeah, so we checked SVG to LAD first just to make sure everything is fine, and then we went ahead wiring retrograde directly. So it's a direct retrograde without antigrade preparation. We can see this is Gaia 2, which went up to distal cap, but from there it is getting diverted, and we can see in the other view how Gaia 2 is going out of the way at the distal cap because of the tough distal cap. So what we did is we switched to Hornet wire, so with the wire escalation from Gaia 2 to Hornet, and you can see Hornet we directed and perforated distal cap, which was very hard. You can see a quick giveaway of Hornet into the distal vessel. So then we confirmed the position and wire exchange to workhorse wire and dilated entire LAD CTO with a 2 mm balloon to create a path for retrograde. And once path is created, so then we took a second wire with the microcatheter into the septal collateral, and always keep a protection wire or into the rescue wire into the distal LAD in such patient. And by then the procedure time was nearly 80 minutes and contrast volume used is 60 ml. So good amount of procedure time was actually consumed till this step. And we can also see another problem with this septal. So this septal is entering exactly at the crux into the RCA, and CTO is also extending up to the crux. That was a problem because wire maneuverability would be quite less in that situation, because collateral enter to distal cap distance was almost none. So we escalated wire to I think Gaia 2 and then to LADS, and you can see the codes of the wire. So it's appeared as if it is in RCA in LAO, but when we came to RAO we realized the wire is in the graft. You can clearly see this is the RCA codes and the wire is quite posterior to RCA, and you can also see the movement of RCA versus wire. So the movement is desynchronous, so which says the wire is in SVZ. And we tried a knuckle wire retrograde, so but unfortunately even knuckle went into the SVZ only. You can see the knuckle and microcatheter just went into SVZ here. So then keeping this retrograde as a marker, we advanced antigrade Gaia 2, and then we changed the wire to LADS as the wire stuck to give a good support to antigrade wire escalation. So we had to do balloon occlusion of microcatheter within the proximal right coronary artery. So with that we could reach with antigrade wire up to the distal cap. But the problem here was the venous graft, which was sitting here, which was giving a loop to right coronary artery. So that's where your distal right coronary artery is more coaxial with venous graft than the proximal RCA proximal to the anastomosis. So that created a problem in reverse cart. So we were not able to connect antigrade and retrograde wires because of the loop in the right coronary artery at the site of distal SVZ anastomosis. we can see this is in two orthogonal views how antegrade and retrograde wires and microcatheter were sitting. Despite repeated attempts, we were not successful in reverse cart, mainly because of the SVZ. And then we tried marker wiring, using antegrade as marker for retrograde wiring and retrograde as marker for antegrade wiring, but was not successful. You can see this is an antegrade wire which went into subintima, and there is a clear distance from the true lumen, almost more than 1 mm. And since the distance from lumen is more than 1 mm, so it's not a good case or good situation to attempt ADR, in this patient. By then, our procedure time was 90 minutes, and we crossed 120 ml of contrast. That's the reason we decided to go ahead with a kind of investment and come back. And what is the ideal investment for this patient? So you had two challenges, which you have to sort out right now. The first challenge is, it's a long CTO, and we have achieved wiring up to distal cap, which itself took nearly more than 45 minutes of time. So escalation, knuckling, and all that stuff. So just dilate this entire area with a balloon till the crux, and create a space so that your next wiring, antegrade wiring, becomes much easier. And the second challenge was his LAD CTO, which took us nearly 90 minutes of time. So we have to keep this LAD CTO patent so that your next retrograde may not take much time. So to keep this patent, we have to stunt, and the disease is extending from ostial LAD, and also LMCA. So we have to stunt from LMCA up to beyond the distal cap of CTO. But here the challenge was positioning of your stunt at ostial LMCA, because to take retrograde next time, your guide you should be able to cannulate left system easily. So for that you can use IVAS to position your stunt at the ostium. So we marked ostium with IVAS, and then we position stunt exactly with IVAS so that there won't be significant overhang into aorta, and the cannulation in next procedure becomes easier. So that's what we did. You can see in this video. So this is a stunt, and so you won't see 360 degrees of overhang. That is what is important, to achieve. You can see here it's a circular stunt inside LMCA, now inside LMCA, and with a good expansion. So this is where we stopped in the first procedure. So we stunted from LM into LAD across LAD CTO, and there is a good flow into distal LAD. And this was the RCA where we left. So we went enter this area with the knuckling, and then we just dilated and created a space. You can see there is a little good contrast flow into the space created. And we took him for next procedure after 3 months, and this was a dual injection. You can see clearly LAD stunt is patent, and there is a good flow into the distal RCA. And antegrade injection we gave with microcatheter, so to make sure we are not going to create an hydrodissection in right coronary artery. And the plan was just to do an antegrade wiring and use this antegrade wire as a marker for a retrograde wiring to overcome or to circumvent the distal anastomosis of SVZ issue created in this RCA. So that was a plan. What we did, basically we went directly retrograde through this shunt, but before sending microcatheter, we did an IVAS to confirm that our wire entry is central in the stent, and then we took microcatheter down. And once my retrograde route is ready, this is caravel which is going quite easily, and retrograde microcatheter is ready at the crux. And then we took antegrade wire escalation. And one thing which is important is we took a distal septal this time, so that to go through the PDA, which gives us good support, rather than the lost septal which was entering at the crux. So we started antegrade wiring with Gaia 2, and you can see because of lost balloon dilatation of entire CTO, you can appreciate the wire is going quite easily in the space which was created. So it just reached distal cap without much resistance. And then this was retrograde wiring using antegrade wire as marker, but again this time also wire was preferentially going into SVC, which we overcame by using Gaia 3, escalating retrograde wire to Gaia 3, and directing retrograde wire in two orthogonal views towards antegrade wire. We could overcome the problem, and you can see now two wires overlapped, and the wires overlapped in distal RCA. So we switched to reverse cart, director reverse cart, but despite repeated attempts, we failed in success connecting spaces. You can see here, we did an IVUS to understand why we were not able to bring retrograde wire into antegrade catheter. You can see this is the retrograde wire, so which was actually you can see here it is in the subintimal space. You can see this is a true lumen, and this is a true lumen where IVUS is, and this is subintimal retrograde wire, and here it actually entered true lumen, but again it went back to false lumen proximally. So here it is subintimal, here it came to true lumen, and again it went back to false lumen. That's the reason we were not able to externalize this wire. And to overcome this, you can see here now again retrograde wire came into subintima. To overcome this, we wanted to advance microcatheter to the place where the wire was in true lumen, and then shift to a Burkhart's wire. But we failed to advance retrograde microcatheter up to that point, and that's when we tried exchanging microcatheter, but still we were not successful in doing so. There was this microcatheter was stuck, and when I was pushing, it was forming a loop. So this was a bit dangerous, which can cause avulsion of septum. So that's the reason we had to stop at that juncture in that septal, and we went ahead with the next septal branch and rewired entire CTO again using antegrade virus marker. And then you can see here we could enter with ultimate bro into the guide extension catheter, which was positioned where the original retrograde wire was in true lumen. So with that we externalized, and then we pre-dilated with a 2 mm balloon, and then we had to wire PLVB because the CTO was extending up to cracks. So we just made sure in IVUS, this is a PLVB, so which is coming from the true lumen. So at the cracks, wire was in true lumen, that is most important. And then we started wiring PLVB using a double lumen catheter, and subsequently we stunted from RCA into PLVB. We can see this is the final result. So good distal flow. So to conclude, post-CABG CTO is very challenging, and SVG anastomose to precrux RCA can fail connection of antegrade and retrograde wires. RAO and LAO views help in differentiating wire position in SVG versus mid RCA, but may not be always. Reverse card close to SVG anastomosis or retrograde wiring using antegrade wire till position till anastomosis as marker would shorten procedure time. In case of procedural failure, scaffold CTO of retrograde tract as a part of investment to make your next procedure smarter and faster. Thank you. To see more such cases, you can subscribe to our channel interventionalstrategies.com.